Good evening, everyone. I'm Dr. Manvitha Rao, physician at Yashoda Hospitals, Hitec City. Welcome to the online webinar sessions hosted by the Department of Emergency Medicine, Yashoda Hospitals. Today, we are going to discuss about the management of organophosphorus compound poisonings, which occurs most commonly as a suicide attempt in farming areas of the developing world and less commonly by accident. To discuss about this, we have Dr. Ameena Afshan, DNB Emergency Medicine, working as a consultant at CAS Area Hospital, Golkonda. Welcome, Dr. Ameena.
Thank you, ma'am. Thank you for inviting me. Good evening, everyone. I'm Dr. Ameena Afshan. Today, I would like to discuss about the organophosphorus compound poisoning. So, one minute. Yeah. So a basic introduction of OP compounds. These are chemical agents. They are mainly used in agriculture. They are also used as a nerve agents in chemical warfare like sarin gas, and also as a therapeutic agents like ectothiopate used in glaucoma. Mostly these are used as a field sprays and pesticides and household chemicals. So as this graph demonstrates that initially out of all the pesticide poisoning, we had aluminum phosphide poisoning more. But recent trends are showing that OP poisoning is increasing. Lot of cases are coming where OP poisoning is the most important compound that is being consumed by the agriculture workers and other people. So basically the classification, they are classified into nerve agents and insecticides. Nerve agents are tabin, sarin, somain, cyclosarin. These are used what not commonly used. Insecticides, they are of two groups, dimethyl group and diethyl group. Dimethyl group has malathion, fenthion, dichlorose, whereas diethyl group has chlorpyrifos, diazinon, and parathion. The distinction here to know is important because dimethyl group are more dangerous because a process called aging happens very faster in dimethyl group. So a person who has consumed dimethyl group, it is very important to start antidote like oxam quickly. I'll explain this later in the slides. So now there is one more classification which divides the compounds into highly toxic organophosphates, intermediate toxicity, and low toxicity. In highly toxic, they are parathion. In intermediate toxic compounds, these are triclophon, and low toxicity are our household sprays like diazinon, malathion. As you can see that highly toxic parathion substances are more commonly used as agriculture insecticides. Now, what is the pathophysiology? How does this poisoning occur? So any OP compound or carbamate also, they bind to the acetylcholine esterase enzyme and they phosphorylate this enzyme, thereby inhibiting acetylcholine esterase activity. Once this enzyme is inhibited, the acetylcholine cannot be degraded. So there is a lot of accumulation of acetylcholine and this prevents the transfer of nerve impulse. So once an organophosphate binds to the acetylcholine esterase enzyme, three things can happen. Either the enzyme can undergo endogenous hydrolysis or it can be reactivated by our antidotes like pralidoxime, or it can go into irreversible binding, also called as inactivation or aging. To shed a more light on this, what is aging? Initially, the binding is reversible. The OP compound binds to the ester site that is initially reversible, but as the time progresses, the binding becomes irreversible. After the binding, which is called as aging, once the aging has occurred, and if you give the antidote, there is no much use. So this is the importance to give antidote before aging. Now, basically, as all of us know, there are two types of acetylcholine receptors, nicotinic and muscarinic at various areas. Nicotinic are mostly in the ganglion and neuromuscular junctions, whereas muscarinic receptors in the stomach, heart, bronchus, GIT, bladder, glands, and pupils. So these are the places where the organophosphorus compounds act, and thereby we have the symptoms. Once they act at the neuromuscular junctions, mostly we have weakness, fasciculations, paralysis. Whereas when they act at the parasympathetic nervous system, the sludge symptoms start coming: salivation, lacrimation, urinary incontinence, diarrhea, bradycardia, bronchoria, and bronchospasm. This is where we commonly say that the patient is drowning in its own secretions. And when the sympathetic nervous system gets stimulated, they have hypertension, tachycardia, mitreus. And central nervous system, OP poisons are very lipid soluble, so they can easily cross the blood-brain barrier. Thereby, we get the central nervous system effects like seizure and coma. So a brief note about pharmacokinetics. They are highly lipid soluble. So they are easily cross the blood-brain barrier. They have a rapid redistribution. Why this point is important? Because most of the OP compounds they get stored in the fat cells. So once we have cleared the blood levels of OP compound, the compound which has got stored in the fat, it starts coming back to the blood. So it gets redistributed. This is when we get again the symptoms of OP poisoning. They have high concentration in liver, kidney, adipose tissue. They have high absorption. They can be absorbed very rapidly through the skin by inhalation as well as ingestion. The main metabolism occurs in liver. So people who have already compromised liver will have more severe effects. The elimination is through urine, bile, and feces. So there are 3 to 4 main clinical syndromes. The acute OP poisoning, which we commonly seen in ER, there is an intermediate syndrome, there is chronic toxicity, and organophosphate delayed neuropathy. So whereas in acute OP poisoning, this starts initially within 30 minutes to 1 hour. It can last up to 24 hours. This is the where we see the main symptoms. This is what is more commonly seen. The muscarinic effects like diarrhea, urination, meiosis, emesis, lacrimation, salivation. The nicotinic effects like fasciculation, cramps, weakness, pallor, tachycardia, and hypertension. CNS effects from anxiety, tremors, delirium to seizure, coma. So and then coming to the intermediate syndrome, it occurs after few days, 1 to 5 days after OP exposure. It is seen only in 40% of the patient. It resolves in 7 days. So here the clinical features are mostly of paralysis, weakness, the paralysis of neck flexor, proximal limb weakness, respiratory muscle paralysis, and muscles innervated by cranial nerves. Here we have to aggressively start the antidote therapy and give supportive measures. Here the most commonly proximal muscles gets involved. The chronic toxicity occurs to somebody who has been daily exposed to some amount of OP compound. These are mostly agriculture workers. They manifest as symmetrical sensory motor axonopathy. They prevent as leg cramps progressing to weakness and paralysis. Here, distal muscle paralysis is more common. So it mimics like GBS. So organophosphate induced neuropathy. So this occurs 1 to 3 weeks after exposure. This occurs because the toxin has damaged the myelinated nerve fibers. So patient presents with impaired memory, mood changes, autonomic or cognitive dysfunction, peripheral neuropathy, and extrapyramidal signs. So how do you diagnose? Now, mostly we read garlic-like odor, but it is very difficult to find because mostly the people they take with other poisons, like they mix it with alcohol. We may not be able to find garlic-like odor. But cholinergic toxitome, that the patient drowning in its own secretion, salivation, lacrimation, bronchol, all this can be seen. And we can also do a cholinesterase assay. There are 2 types, plasma cholinesterase and RBC cholinesterase. Those plasma cholinesterase, they recover within 4 to 6 weeks. They may be normal in chronic and low exposure and decreased in 50% of asymptomatic patients. Whereas RBC cholinesterase, they recover in 12 weeks. They are very accurate indicator. In moderate toxicity, they are decreased up to 10 to 20%, whereas in severe toxicity, they are less than 10%. So there's a WHO classification of severity. It has classified into mild, moderate, and severe, taking cholinesterase and the patient's sign and symptoms. So in mild, the cholinesterase levels are between 2 to 8, and the patient can walk, talk. He has some amount of abdominal pain, nausea, vomiting, headache, salivation, and sweating. Whereas in moderate, the levels have decreased to 0.8 to 0.2, and he talks with soft voice or cannot talk, fasciculation, meiosis, anxiety. Whereas in severe, where the levels are less than 0.8, coma, confusions, convulsions, and bronchial secretions may be present. So other tests, what we can do is CBP, leukocytosis will be seen, hemoconcentration, RBS, hypo or hyperglycemia. Hyperglycemia can be seen because of the adrenal medulla secretion, stimulating hyperglycememia. ABG show initially metabolic acidosis. Once the paralysis, respiratory muscle paralysis sets in, the patient will shift to respiratory acidosis. Electrolytes like hypomagnesemia elevate amylase and lipase levels. When the poison is consumed in large amount, it can even cause pancreatitis. So it can cause elevated amylase and lipase level, elevated troponins, chest X-ray show pulmonary edema. ECG can have prolonged QT, ST wave changes. So this is a cholinesterase 400 kit. Very rapidly we can get the results within 4 minutes. So now treatment. Like for any poison, we go with airway breathing circulation. That is the first thing. So monitoring the patient with the cardiac monitor, pulse oximetry, giving oxygen, decontamination. Decontamination is very important, not only to the patient needs, because it has rapid absorption through the skin. So we have to decontaminate the patient thoroughly, and caregiver safety. As I've already said that it is a highly lipid soluble, so it has very good absorption. So the health personnel who are handling the patient should be very cautious. They should wear gloves, they should wear a gown, mask, and goggles also if required. So because we cannot let ourselves get poisoned. So other things, what can be done? Gastric lavage, activated charcoal, hemodialysis, or hemoperfusion. I'll go in detail. So decontamination and supportive therapy. If patient is comatose or vomiting, put him in left lateral position, head down with neck extension to reduce the risk of aspiration. If still the airway is not painted, go for intubation and control the seizures with diazepam. And frequent suctioning of secretions, because they have lot of secretions. And oxygen therapy as and when required. If the patient has any other hair accessories, clothing, everything should be removed, and the patient should be thoroughly washed with lot of soap and water. Skin folds, under nails, everything should be washed particularly. For eyes, just with water or normal saline is enough. The healthcare workers need special protection. Mostly if they use rubber gloves and gown, they are more recommended, as these compounds are known to penetrate latex and vinyl gloves. So gastric lavage, it is good, it is useful if we do it within 1-2 hours of ingestion. Within 20 minutes, the gastric lavage can decrease about 40% of the absorption. After 1 hour, it decreases to less than 10%. So if the patient comes within 1 to 2 hours, we do a gastric lavage, that is more good, beneficial. But it has its own risk, as we know, aspiration, hypoxia, laryngeal spasm, and it reduces the proper management of airway. Activated charcoal, it reduces the poison load by absorbing it. This is also highly debated whether it is good or not good, but single to multi-dose activated charcoal are given in routinely, but cathartics and induced emesis should be avoided. So this is an article where they have done a study to see whether charcoal versus 50 gram of activated charcoal, what is the use. They found that mortality did not differ between these two groups. We can use it, but not much benefit has been come. Now coming to our antidote, atropine. So what it does, it competitively blocks the acetylcholine. Initially, we give about 1.2 to 3 mg IV, 0.05 mg per kg in pediatrics. We double the dose at every 5 minutes by seeing the signs of atropinization. If we are able to achieve, then we go for infusion. So what signs clearly we see is, first and the most important sign is clear chest. Those secretions should be cleared. Heart rate should be more than 80 and systolic blood pressure should be more than 80 mmHg. Previously, much attention was given for bidriasis, but rather than that, clear chest, increasing heart rate, increasing the blood pressure is more appropriate. Now in detail, this is a specific antidote for the muscarinic effects. It reverses the life-threatening features like the central respiratory depression, the bronchospasm, the bronchial secretions, and severe bradycardia and hypotension. There are 3 regimens which are mostly followed. One is an incremental dose regimen, one is a bolus dose regimen, one is a continuous infusion regimen. So incremental dose regimen is to attain the target endpoint. We give small amount of doses to attain the target endpoint, followed by setting them at infusion. Bolus doses, we give 2 to 5 mg every 10-15 minutes, and then we see. Continuous is, we give a continuous infusion, 1 mg per minute, till the atropinization has occurred. So the target endpoints, as I've already told, heart rate more than 80, dry axilla, systolic blood pressure more than 80, and clear chest. Last, dilated pupils. The recommended dose as per WHO is IV bolus of 1.8 to 3 mg with subsequent doses doubled every 5 minutes. If there is no response, then we double the dose and repeat till the atropinization is achieved. Once the atropinization is achieved, we give a maintenance dose. That is nothing but 20% of the initial atropinizing dose for about first 48 hours. Then gradually we taper it over 5 to 10 days by continuously monitoring the patient. Now, one thing we should be very cautious while giving atropine, to look for atropine toxicity. The patient presents with agitation, confusion, hyperthermia, urinary retention, severe tachycardia. It can also precipitate ischemic events in patient who has underlying coronary artery disease. So when you have seen that patient is going into over atropinization, you discontinue the atropine infusion, for some time, observe the patient, and when the symptoms settle down, when they come down, then again start at 70 to 80% of the previous age. Or we can use another anticholinergic agent like glycopyrrolate along with atropine. It can be used along with the atropine or only single glycopyrrolate. But many studies have shown that using atropine plus glycopyrrolate is more beneficial rather than using a single agent. But glycopyrrolate does not enter the CNS systems. There is no blood, it doesn't cross the blood-brain barrier. So initial muscular excite like coma and drowsiness will not respond. So when do we use it? When there are copious secretions as an adjunct to atropine, when the features of atropine toxicity have come, and when atropine is not available. So the usual dose is used as 7.5 mg of glycopyrrolate in 200 ml of saline and is started as infusion and is titrated to the effects. Now coming to oximes, what does they do? Now we previously atropine was an antidote. Now we are reactivating the acetylcholine esterase enzyme. So what does oxime do? It reactivates the phosphorylated acetylcholine esterase enzyme and thereby regenerates the enzyme activity. The dose is 30 mg per kg IV over 5 to 10 minutes. Then as an infusion about 8 mg per kg per hour for 24 to 48 hours. So PAM is not recommended for asymptomatic patients in carbamate poisoning. It is very good, effective if we give it before aging. So how does they work? They work by reactivating the acetylcholine esterase. Acetylcholine esterase enzyme has an anionic site and an ester site. The OP compound binds to the ester site. The anionic site is free, where the oxime come and bind, and then it forms a bond between with the OP compound. So OP and the oxime will get released from the enzyme. The enzyme will get reactivated. So the most commonly what we use is pralidoxime. So it is the most common oxime available. It is a neutrophilic agent. There are other oximes as well, obidoxime, trimethodoxime. So the therapeutic window for this, the limitation for this is aging. Give before aging. So the dose as I've already said, 30 mg per kg bolus IV over 20 to 30 minutes followed by continuous infusion. And the infusion is continued until recovery or 12 hours after the atropine has been stopped. The largest oxime trials recommends 2-gram loading dose followed by 500 mg per hour for maximum 7 days. There can be some side effects like dizziness, headache, blurred vision, diplopia. These are the common side effects. The stable phosphoryl oxime that has been formed, it has it regains the high anticholinesterase activity. Rapid administration can lead to tachycardia, laryngospasm, muscle spasm, and transient neuromuscular blockage. So this is a chart showing that based upon the time, if we give within few hours, oximes have much effect. Whereas as the time passes, they are coming into more hazard ratio. They are coming, there is more harm than benefit while giving these oximes. So time is very important. As you can see, for those patients given less than 4 hours, it is beneficial. And where it has been given more than 4 hours, it is not showing so much benefit. It is showing more harm. Now, treatment of complications. There are some other complications can occur. Cardiovascular complications, mostly bradycardia, hypotension response to atropine. Whereas severe hypotension persists, you can go for vasopressor. While nicotinic receptor stimulation causes sinus tachycardia and hypertension. ECG changes like prolonged QTC and travel ST segment elevation, extrasystole, these also can be seen. For respiratory complications, suctioning, high flow oxygen, and intubation. For intubation, indications for ventilatory support, when do we intubate? So if somebody is having PaO2 less than 50 mmHg on room air, where the CO2 is rising to more than 50, PaO2 FiO2 ratio is less than 250. For a patient who is having respiratory rate more than 35, vital capacity is decreasing less than 15 ml per kg. Some other supportive treatments that can be given: antibiotic prophylaxis, hydrocarbon aspiration, because some patients they can aspirate as well, so that can cause chemical pneumonitis. Furosemide, if somebody's not, some pulmonary edema is not responding even after atropinization, we can go for diuretic therapy. Soda bicarb, this increases the blood pH and have been reported to improve the outcome in animals through the mechanism is not clear, but this is useful more in nerve gas poisoning. The dose is 5 milliequivalent per kg over 1 hour, followed by 5 to 6 milliequivalent per kg per day. There are the roles of FFP, hemodialysis, hemofiltration are not yet clear. Some studies have shown that hemofiltration, hemodialysis are more they are beneficial if started early. Magnesium sulfate, it blocks by blocking the ligand-gated calcium channels. Calcium channels are present in the presynaptic neuron. So once the calcium channel is blocked, the acetylcholine will not get released. So by this it decreases the acetylcholine concentration in the synapse. So in this way, magnesium sulfate is useful. The dose is 4 gram initially on the first day, have shown to decrease hospitalization period and improve the outcome. Clonidine, this is an alpha-2 adrenergic receptor agonist. It reduces the acetylcholine synthesis and release from the presynaptic terminals. Animal studies have shown some benefit. The dose are 0.15 to 0.30 mg per mg IV bolus, followed by 0.5 mg over 24 hours. Salbutamol. Salbutamol, this might complement atropine during resuscitation by treating the bronchospasm through the beta-2 agonism. However, it will also help to increase the elimination of fluid from the lungs. So, but a study at BAL-T2 study, it has shown that IV salbutamol has not shown that much good benefit. But this is unrelevant to the poison patient because we are giving in the form of nebulized form, and this will be we are giving in the during the resuscitation time. So using this can also be advantageous. Lipid emulsions. Lipid emulsions, as we have commonly used for lipid soluble surfactant toxicity. OP compounds, they are highly lipid soluble, and the solvents that are used in these pesticides, they are also lipid soluble. So using a lipid emulsion can be as a newer management. But a rodent study of unformulated palathion have shown little benefit. There is only one case report that has shown that a patient after parathion poisoning had gone some benefit after lipid emulsion therapy. So conclusion, although multiple antidotes are present, but only atropine has a clear-cut beneficial effect. Oximes are good when they are used rapidly and initially. So, and it is only possible that a ban will prevent these deaths, because if 2 lakh people continue to die from OP insecticide poisoning, the banning is much better here. Thank you.
Thank you, Dr. Ameena, for such an elaborative session on the management of OP poisonings.
Thank you, ma'am.
Yeah, thank you.